Yeah. Are we done? Shorthand. Shorthand. Also, we'll put it on back on later. Tissue injury. So what do we have if we wrap everything together? First of all, this is in your book to make everybody happy. Tissue injury. First attempt of the body to do tissue repair. That's a release of prostaglandin. We're getting a sensitization of the four endings. Substance P goes up, sensibility of the 3B fibers go up. This is the first phase of the hyperalgesia. This supports the tissue repair, vascular and cellular. You will get a decrease of action. After that, you can do whatever it takes. Anne told me yesterday about that's why you have a couple of days to get out of somewhere. Can you repeat that? That was kind of interesting.
When we do backpacking, when we have often, not often, but when you come up with problems with people really twisting out their knees or ankles, we realize that we've got a certain amount of time that they can walk out, otherwise we're going to have to carry them or have a helicopter come in.
And as we know now, and you know now, if you have somebody, let's say Helen Hunter, or what's the lady's name, with those long legs, you will have 6 days to get out of there. And if you have short legs, you will only have a day, because it is 400 millimeters a day. So, better go quick, because you have short legs. Okay, cortisol. I mean, it is not all bad, of course, what happens. I mean, the cortisol also has a function. I'm not saying that it is rubbish, that we have a stress hormone. That's not true. Suppose I'm in a tree. I'm in a tree and we have a gate there or a door I need to go to. There is my castle and I'm in a tree and there are wolves below me. Or wolves are coming. So I jump out of the tree and I twist my ankle. I have a fast pain twitch. And that's fine. You will be in a complete alarm phase, believe me. With wolves coming and you have to go to the gate. So you will go to the gate. But how in the world are we able to do that? We are able to do that because you're going into a complete alarm phase. That's number one. So the cortisol kicks in. So there is no release of prostaglandin. If there is no release of prostaglandin, there is no release of substance P. So no edema at that time. So you can get away and the wolves are the bad guys. And everybody lived happily ever after.
Does the same thing happen in maybe a less life and death situation when someone's playing in a sport?
Yes.
or goofing off in the backyard and they're occupied?
Yeah, I think so. Yeah. Especially if they're really involved. I mean, the cortisol must be released. And it's, again, it is also the cortex, of course, and it is also the degree of the sprain. I mean, not everything is quite cut and clear, but on the sports field, certainly. Yeah. Because they are most of the time already in an alarm situation. Especially when it is football. So what we do have is dysfunction. Dysfunction can be a local problem, local soft tissue changes, and no changes in the rest of the segments, or less changes. What we also can have is a segmental problem, so it goes further. If it goes further, we will have soft tissue changes in the segment and soft tissue changes on level of direct spinal somatic segment. That means that we know now that, for example, if we have a ankle problem, a lateral ankle problem, we're in dermatome. I got you. L5 is 1. Okay, L5 is 1. So we are on that level. Okay? Perhaps the ankle problem, and we are now level 3, so we know that by now. Perhaps the ankle problem has to do with decreased activity of the peroneus. It could be everything included. So it could be a spinal problem. Suppose it wasn't a spinal problem. Still, we could have soft tissue changes in the segment. And we can have soft tissue changes on the level of direct spinal somatic segment. So we can have the substance P reactions on an L5S1 level. That is a possibility. And for example, a hip problem, you would go higher, of course. A knee problem, you would be on L3, L4. Is this in your book? I think so. No? So, what do we have? If you have a local problem, then perhaps you must also check out, especially if it is a longer time period there, if there are changes in the spine. Because if we have soft tissue changes, we will have also other changes, and this is what I'm going to put on now. If it is real short, we will have a short-term arthritis. And arthritis, I mean, is not rheumatoid arthritis. We will have a contraction of joint capsule. We will have an increase of synovial fluid, so it will be more unstable. Decrease of quality synovial fluid, an increase of local temperature, insufficient feeding of cartilage, an increase of nociceptive activity. And this is short term. This is if it is there not too long. If you're going to talk about long-term arthritis, then there will be a change of the morphologic structure of contracted joint capsule. There will be a decrease of synovial fluid, a decrease of quality, a decrease of quantity. Quality cartilage and synovial fluid. A decrease of subchondral bone, a decrease of proprioception, and a nociceptive activity with movement. So if you are in rest, it is in rest. Then it won't fire off. Important for us to know if we see a patient is number one, why is there a dysfunction? Why is there no spontaneous recovery of the dysfunction? Why doesn't the body heal itself? Why does somebody have a knee problem for 2 months? So if somebody comes into your clinic and say, I have a knee problem or I have a pain in my shoulder since 3 months or since 4 months, then you might ask yourself, why is it still there? Instead of it, what's wrong? Why was the body not able to heal? Is there something going on? Is the person in an alarm situation or not? Is the dysfunction a dysfunction, or is it a functional adjustment to changed and threatening circumstances? What Earl said about the flattening foot or the flat foot, that is a functional adjustment. And if we're going to restore that with an orthotic, we will be in trouble. An arthritis, perhaps it is to help us, to guard us, nociception. An arthrosis, why do elderly people have arthrosis? Because they don't move as much as children. Perhaps we must turn it the other way around. Instead of trying to get rid of the arthrosis, perhaps we must respect it. If somebody has a forward head posture, I hope nobody is doing chin tucks anymore. Because it has a function. And even arthrosis has a function. There is less motion, there is less movement. The patients are older, they don't need it anymore. Spondylolisthesis, even that could be a functional adjustment. Osteophytes, hypermobility, instability. What? Okay. So these are the questions we can ask ourselves. This is what we looked at yesterday. Assessment of the dysfunction. We are doing that all day. I mean, we're doing this in this course. We are trying to assess the dysfunction. Assessment of the relation between the load and the loading capacity. We will take a look at that. Assessment of the selectivity of the nervous system. We know that. Because we talked about it yesterday, we talked about it today, what selectivity is and how we can assess it. Assessment whether this dysfunction is an indication for manual therapy or for physical therapy. What David already a couple of times mentioned is perhaps we are doing sometimes too much. Or perhaps we must also realize that if we do manual therapy, this is what we can do in manual therapy. And this is absolutely not manual therapy. Or this must go to somebody else with NDT or with muscle energy or back to the physician. We are no wonders. Perhaps we must decide really what can we not treat? What is contraindicated? Which precautions do we need to take? Instead of treating everybody. I will talk briefly about the assessment of a relation between the load and the load capacity. Load is the force applied to the tissue. This may be tensile, compressive, bending, torsional, perpendicular combinations. We know that. I mean, this should everybody know. This is also how we load our structures, how we load our ligaments if we have an injury and there is recovery. Basically, what we can do is on a sheet of paper, we can write down a square. This is the load, local, general, and this is the load, capacity, local, or general. Is it load capacity or load tolerance?
Capacity.
What?
It says capacity.
Yeah. But is load tolerance, is that a better name? Whatever. So we have a load and we have our load capacity. So if we fill in this, so if we have a patient who comes in our history, then we can ask him questions. And then we can write down on this square what we think or what the person is doing. And perhaps you can zero in on that and say the load is too high, the local load is too high, or the general load is too high. Then we're going into selectivity again, into alarm phase, adaptation phase. Or perhaps you must say there is something wrong with the load capacity or the load tolerance. Perhaps we must increase that. So either we must get the load down or the load tolerance up, or the load capacity. And perhaps on a general level or on a local level. It will be on the board. Local load, work postures, activities, recreation. What kind of recreation, the duration and the level of it. So what does the person do? Local load. General load, do you smoke? Do you use alcohol? Do you have medications? Psychosocial. If somebody is in the middle of a divorce. Mother-in-laws. Big stressor. Work and I have that thing with my mother-in-law. The next time, I have a mother-in-law and she lives in the Netherlands. The next time she's in, I will bring her in. She is amazing. I mean, my wife, David, my wife is really beautiful, isn't she? She is really beautiful. My mother, she must be adopted. I mean, has nothing to do with it. My wife is this high, this tall, and she's slim, and my mother-in-law is this size. And okay, I will send this tape to the Netherlands. And she loves me, by the way. At Christmas, they were 6 weeks here. Can you imagine? 6 weeks in one house with somebody else, with my mother-in-law. Work environment, work pressure. I was in a complete arousal state after that. Okay, so this is the load. Now the load capacity. Local. What do we have? Previous traumata, surgical intervention, referring sensations, congenital anomalies. General level, viral diseases, systemic diseases, non-specific arousal. What do we have here? What can we do with it? Perhaps try it once. I mean, if you have a patient, try to ask what his load is on a general level, on a local level, work tolerance. And after you read it afterwards, perhaps you can say, I would like to get this down. Perhaps the arousal must go away. Perhaps you must work on that before you do anything else. I'll put this back on so for the people who didn't have that on. If you're done, please let me know. What we will do now, we'll do a couple of case histories. Just simple case histories, and I will put them on the board and think about it, what you think what the treatment would be, or where the angles are, what kind of problems. And I will tell you already, because it's the end of the day, it has to do with selectivity. It has to do with alarm phases, adaptation phase, and it has to do, are we within the 90 or the 120 days? What kind of criteria do we have to use? In what kind of recovery process is the patient? And how would our treatment be? Okay, here we have the manager again. We have a manager, comes into your clinic, works 80 hours a week, is divorced, has 7 children, has to make budget every month. David and I, we know now what that means. Sympathetic reactions, so the person is sweating, doesn't sleep well, etc., etc. Has a torn ligament in shoulder resulting in a contracture of the capsule. Radiating pain to neck and periphery. 5 months post-injury. What would you say about this person? What? Tough. We know that. Okay, so what would you say about selectivity? Low selectivity. Okay. Would this person, could he be in alarm phase? Sure. Okay. So what kicks in? Cortisol. We talk about 90 to 120 days. Is this person over? Yes. Could it be influenced by cortisol? Perhaps he is exactly on the line. Perhaps we can do something with him. Because of the timeline. Because with the cortisol kicking in, regeneration process is down, the time is down. So perhaps we can do something with him. What would we do with him?
Send him to a stress management.
We can send him to a stress management class. Okay, that's number 1.
You lost me.
Okay.
Okay, are you saying and making a case for the fact that it's good this guy's under this situation just because of the timeline and the face of the injury?
It will definitely have to do it. I'm not saying that I'm a favor of it, because basically if he wouldn't have been so low selective, it would have already have resolved.
Yeah.
So perhaps that's why he still has that problems. Because the regeneration process is so slow. So perhaps we can go in and say, okay, well, we can mobilize it. We can still try to lay the collagen down. It is not a lost cause for us. What I would do with this person is definitely get him out of the alarm phase. That's number one. And he has to do that. And I'm not a counselor, and I will never be a counselor, believe me. What I would say to him is, for example, do you have to work so hard? I mean, wouldn't you do something else with it? And if he said, well, no, well, okay, that's his problem. But I would explain to him what's going on. I would explain to him that he's in alarm phase. And that if he doesn't go out of that alarm phase, he's in trouble. And he will be in trouble for the rest of his life. Then I would work on his shoulder. Of course I would work on his shoulder. There are sympathetic reactions, so perhaps I would go into that. Perhaps I would go into the segment, into the complete segment, instead of going in and do frictions on the shoulder with a person with a low selectivity, which will definitely increase the alarm phase.
Do you know, or maybe the person who works with a psychiatrist know, are there medications that people take that can, if they can't, by changing their environment to get out of their arousal phase, are there medications that bring them out of their arousal phase, chemically? And what are they?
That's where they use the
Like
antidepressants and the anti-anxiety drugs. And yes, the guy that I know and have dealt with in the past, that's his specialty area, and that's one of his big proponents when we talked about treating chronic pain patients, is that, you know, you're not going to change their psychology overnight, so use these chemicals to change it from a chemical standpoint. So he's saying because these will reduce cortisol levels.
But once you reduce the cortisol, is the cortisol helping to keep whatever inflammation is there a little bit in check? Or when you take away that effect, do you then get a blowout of their inflammation?
If you keep the cortisol in proportions, there will be a nociceptive reaction. And we need that for the regeneration, because that's the basis of the regeneration. That's the basis of the recovery.
Feel better about it.
What? What?
Well, could their pain increase upon going on these anti-anxiety?
Pain has nothing to do with nociception. Pain has nothing to do with this story. I mean, okay? So don't forget that pain and nociception is two items. Okay? More questions about this?
If you just change that case study a little bit to say this was a person who had, let's say, a high selectivity
Yes.
and not some of all those alarm stages, and was 5 months past with this shoulder injury,
Yes.
then your mode of approach would be different, because you're thinking, we're not going to affect healing of that particular tear unless he wants to get surgery to repair it. So we're going to have to go in a different mode of maybe,
Yes. Or I would re-injure it.
or re-injure it.
Yes.
Friction,
What?
and that's how you can do it with the friction.
Yes. You re-injure. If it is local, if you have a capsular pattern, probably with a friction you won't do anything.
So that manipulation.
Manipulation or really stretches, exercises or whatever. Okay? So the selectivity is very important. But if this person has high selectivity, why the heck has he still problems?
Well, maybe you have a significant tear.
Yes.
that you-
Then he has to go back. Yes. Absolutely. Excellent question. Okay, somebody else. Young athlete. Injury 3 months ago. Light contracture. Let's say a knee or something else, but it doesn't matter what it is right now. High selectivity, and is definitely an adaptation phase. If I would see this person, number one, he's young. Number two, he has a high selectivity. We're coming back to the remark we made before. Why does he still have the contracture? Why does he still have problems? So we really must determine then what is going on. And if not, this might be morphological set, even if it's right on the line, because he's young, and perhaps that will decrease the time. that we have to get somebody better into the full range of motion. But this person, without a doubt, I mean, it's an athlete. You would go in and try to restore it any way you could. Any way. Because you wanted to get him out as soon as possible. Am I right? And perhaps now we can explain why we would do that. Why we would choose for options. This is the last one. Female, 45 years old, fell and fractured wrist 3 months ago. Complains of intense pain. Pain in the arm, swelling, sympathetic reaction, SRD. Physician's orders are mobilize the wrist. If we want to keep the physician as friend, then we are in trouble. I mean, a lot of physical therapists would mobilize the wrist. But basically what we have to do is get the pain away, take a look at the entire scope, at the segment in which we are working. We have to take a look at cervical area, we have to take a look at thoracic area, and we have to get the selectivity up. We have to get this person out of the alarm phase. And the alarm phase might be created by the physician, or it might be created by the other PT who said, stop whining so much. Move that thing around. And perhaps he will create an alarm phase for her. That is something we have to realize. If you have somebody that comes in from another clinic, we must really find out how did the other clinic treat the patient. And in what stage is the patient, in what phase. I would definitely do with her pain control, that's number one. Stimulation of the 2 and the 3A fibers. Functional movements as soon as possible, PNF patterns, even if we're moving around in this pattern, who cares, or in this pattern. Functional motions, what can the person do? Information to the patient, what's going on. And also tell her there's nothing else going on, because a lot of these patients think they have cancer, or it is osteoporosis, or it is something else. And the physician's order mobilize the wrist. Definitely I would perhaps mobilize the wrist, but with grade 1 oscillations. I mean, we can do something with the wrist, but I mean, it depends on what you want to do. But the most important part is that I hope that this has given you a little bit food for thought, that perhaps it is a little bit different, or there is more out there than perhaps what we think. And perhaps if we can integrate the nociception, if we can integrate the selectivity, and integrate what we feel and what we think about it, perhaps we will be better therapists. This is the end of my story. If you, again, if you don't feel comfortable with this, that's fine. I mean, not at all. But I hope that you will think about